Welcome and thank you for joining our webinar today, which is organized by EuroHealthNet and the European Observatory on Health Systems and Policies, and which we are organizing also as part of the European Public Health Week, which today's theme is Health Through the Life course, Breaking Down Silos. And breaking down silos we will, as a topic for today's webinar is social prescribing, dismantling silos for community well-being. My name is Ewout Verginneken of the European Observatory, and I will be moderating this webinar together with Alison Maassen from EuroHealthNet. And Alison will also keep an eye on the chat box. So please, if you have any questions or comments, put them in the chat and we will get back to them later. In our webinar, we will learn, of course, what social prescribing is and also how it can connect people to activities, groups, and services in their community to meet practical, social, and emotional needs that affect their health and well-being. We will also learn from different countries, different approaches, as the way it is implemented varies widely among these various jurisdictions. We will start a webinar with a keynote overview from Giada Scarpetti from the TU Berlin and the European Observatory. And she will talk about a paper that we have done together as a collaboration between EuroHealthNet and the Observatory, actually the Observatory's HSPM network to be precise. And then we will have 3 spotlight speakers. First will be Andrew Barnes from the United States, who will be more looking from an organizational level. Then we will hear from Daniela Royats from Austria, and she will be talking more on training. How do you do training for social prescriber workers? Then we will go to Cristiano Figueiredo from Portugal, and he will look at how social prescribing is implemented at practice level. We will also have reflections at the very end from Caroline Kostongs, the director of EuroHealthNet. But before we go to Giada, we will first go to my co-moderator, Alison, who has a poll for us. So Alison, please.
Yes, thank you so much, Ewout, and good morning, good afternoon, depending on where you're joining us from. You should see a poll that's come up on your screen now, and the poll has 2 questions. The first is, has social prescribing been attempted in your country? It has a single choice, yes, no, I don't know. I see some people already responding, so that's very welcome. And our second question asks, what challenges do you anticipate in integrating social prescribing into existing healthcare practices? And you'll see a multiple choice, fragmented systems, resource constraints, cultural competencies, community engagement, data sharing and privacy concerns, resistance to change, and policy and regulation barriers. And I see quite a horse race happening there in the poll already. With a lot of responses. So thanks for responding. We're going to leave that open in the background so that you can continue to respond or to think about it as we hear from our first speaker, Giada. So with that, maybe I'll hand back to you, Ewout.
Yes, and then I can immediately hand over to Giada. So Giada, take it away.
Thank you very much, Ewout and Alison. Good morning, everyone. I'm sharing the screen right now. So today I'm going to talk about how social prescribing is being used in different countries around the world to help improve health and well-being for their communities. And we will do so by looking at the key results we identified in this paper that Ewout just mentioned. It was published at the beginning of the year, and it was a collaboration with country experts and network members from both the European Observatory, the HSPM network that Ewout mentioned, and EuroHealthNet. We had a wide geographical coverage. We included Australia, several countries in Europe, and North America. These also meant that we had different types of health systems, such as tax finance, health insurance-based, and mixed systems. We gathered the evidence through a survey that was based on the WHO Health System Framework, also known as the building blocks, and we identified 5 main areas of focus that you can see here on the right of the screen. So during this presentation, I will touch upon these different topics. And first of all, we asked the countries, how do they define social prescribing, and what links are there, if any, to the health system? Then we looked at the scale and the scope of the programs in the countries. And then we focused on the workforce, followed by financing. And then at the end, we looked at the evaluation and evidence. And I just wanted to quickly point out that since social prescribing is a very constantly in motion field, the data was collected in 2022. So something just to keep in mind. So first, How did these countries define social prescribing? We saw that there was no unanimous definition, but the common feature was that social prescribing was thought of as a treatment strategy, a formal pathway that connects patients to local non-medical resources. So we know that many things affect our health and well-being, so there are issues that cannot be fixed with traditional approaches or medicines. For example, if a person has poor housing conditions, that can have a big impact on your health. So the goal is to help people with a variety of issues, isolation or lifestyle-related or even practical issues, if you need any legal advice, to find out interventions that are tailored to your individual needs. What this might look like, for example, if a person with hypertension might be interested in daily walks with a group, or, for example, cooking classes, or people who are isolated, social prescribing really caters to the need for human to connect. So it seems very simple in theory, but sometimes we don't do it for a variety of reasons. So how does it work in practice? We found that there are different models that are being used throughout the different countries, but usually everything starts with a conversation. And this conversation could be with a GP in a practice, or with, in some cases, link workers, also known as community navigator, or other health professionals. So the patient really talks about their individual needs and is a co-creator of their prescription for social activities and non-clinical services that are already available in the community. Why is social prescribing gaining attention? Well, it provides a very holistic approach to health, and as we saw, it can give very individualized care. It also promotes community engagement for communities to thrive, and has the potential for offering preventive care and a potential reduction, therefore, of healthcare costs or utilization. So if a patient has their needs met through social prescribing, they might be less likely to visit their GP or the emergency department. And since the patients are very much involved with their interests and passions in creating their prescription, it leads to also patient empowerment and inclusivity. So one can wonder what the difference between social prescribing and programs that address social determinants of health could be. These programs are interconnected, but in a way, social prescribing is very much tailored to the individual, while social determinants programs are more at a general/government level. So this is a broader focus rather than the very individual for social prescribing. Going back to what we looked at in the paper, so we wanted to have a look at if and whether social prescribing is linked to the health system. So in general, the only exception, was the Netherlands that you see here in blue, where social prescribing is linked to the work of municipalities, so it's outside of the health system. But in all of other countries, the common denominator was that social prescribing is present in primary care everywhere, but in some other instances, so you see in different colors, for example, in the yellow, also secondary outpatient care is available for social prescribing, and in the pink, also inpatient care. So it paints a very different picture. What we looked at in terms of scale and scope was that implementation was very different across the 12 countries. So we range from pilot programs, as we saw in Portugal and Austria, to municipality level, for example, in the Netherlands, and then to wider countrywide rollout, as in England, where social prescribing has been in place for a long time. So social prescribing is suitable for all individuals, but we found in the paper that usually it targets specific populations. One example was in Portugal, on communities with a high proportion of migrants. In general, we see it also for older adults who tend to be perhaps isolated or have issues, or people with chronic diseases. But it was also interesting to see that now the attention is moving on to young people as well, with some examples in Austria and the US. For the next theme, we looked at the workforce. And again, the picture here is very different. In England, since it's been around for quite some time, they created a separate role for linked workers. However, in most programs, the existing staff is used for social prescribing. So, for example, in Portugal, we have social workers. And in general, the countries reported no formal training for people involved within social prescribing, although we saw some exceptions, for example, in Austria and as well in Slovenia. But we're going to hear about this later. For the next topic, we look at the financing. And again, very different depending on the country you look at. In the United States, grants and research funds played a big role, especially for randomized controlled trials. And in various states, also Medicare and managed care organizations were involved in covering expenses for linked workers. In the example of Austria, this was through funding calls from the Ministry of Social Affairs, Healthcare and Consumer Protection. And in Portugal, the linked worker salaries are funded through the budget allocation for the family health unit, but also supported by municipality. In other instances, in other countries around the world, also philanthropic and charitable organization played a role. So it is very much evolving and a very varied range. Coming on to evaluation and effectiveness, I am sorry to disappoint, but there is not a lot of robust evidence. There is preliminary evidence to suggest that there are some benefits. So, for example, in Austria, a relief of physicians' work burden and also patient satisfaction. And from Germany and the Netherlands, there was some evidence of reduction of healthcare consumptions and therefore cost effectiveness. However, since social prescribing is very context dependent, measuring impact to then compare on a national level can be very challenging. So there are some things that need to be taken into consideration. So far, we have seen what social prescribing could look like, but what is it like in reality? So these are just some of the challenges that I want to list, and then I'm curious to see what the poll will look like. But we saw, first of all, that the willingness of the participants to be part of the social prescribing activities is crucial. Some people might not be interested, some people might question their usefulness. Second, if there is a pronounced division between the health and the social sector, this might very much hinder true integration of services. And then number three, patient tracking through very different activities might be hard, and there might not be a follow-up process in place. And number four, funding instability. This might question the longevity of the program and also raise questions about the remunerations for people involved in social prescribing activities. And then the last point, it's part of a bigger discussion, but it's about the medicalization of social issues. So on one hand, it becomes socialization becomes more formal, let's say, but on the other hand, individuals may be more likely to participate if the referrals comes from a professional. So just some food for thought. And then finally, to wrap up, is social prescribing a silver bullet? While it might not be a silver bullet, social prescribing contributes to a more holistic and patient-centered approach to healthcare. So it could be seen as one component of a comprehensive healthcare strategy, perhaps an intermediate goal for integration. Since social prescribing is very much dependent on local context, the needs of the population, and the resources that are already available in the community, this is linked to the effectiveness as well of the interventions, because it depends on the quality of services that is available already. Next, of course, we found that supporting health and social care workers is crucial, and the potential to help them is through clear frameworks that clearly state roles and responsibilities, adequate funding so that we know that the program can be in place for a longer time, as well as training policies. And then finally, we need further research to shed light on specific aspects of social prescribing. Thank you very much for your attention.
Thank you very much, Giada, for this overview. Very helpful, laying out all the issues that we will be discussing today. Do download the paper. It's open access. It's linked in the chat. And now we will go to see the results of our poll. So over to you again, Alison.
Yes, thank you. So I see here, and I hope all of you see as well on your screens, has social prescribing been attempted in your country? And we have yes as our leading response, 47%, no, 23%, and I don't know, 30%. So it seems, yeah, that would indicate that all of you or many of you have had the opportunity to see some social prescribing. Well, let's say around half have seen the opportunity to see it in your setting. And in terms of challenges, yeah, really quite a mix I see here. I wonder, Giada, if you might want to react to this question based on your findings from the paper, what you see here, if you feel that this is an accurate reflection.
Very quickly, yes, I mentioned some of the challenges in the slide, but different countries, of course, pointed out a variety of challenges, and I think it's very much reflected in how the poll is also looking. So there was no one primarily that was sticking out.
Context specific then, as it seems. Yeah, that was one of my biggest takeaways indeed, is how context specific it is. I see tons of questions coming into the chat already, so I'm going to start working on grouping those, but I'll for now hand back to Ewout. Thank you so much.
Thanks, Alison. And now we are going to our spotlight speakers, and we will start with Andrew Barnes, who is joining from the United States. I don't even want to know what time it is in Richmond, but we really appreciate it for you making the time to join us here. You were a co-author actually of the paper. Andrew, for who don't know, Andrew is a professor of health policy at the Virginia Commonwealth University in Richmond. And his research interests include substance use policy, tobacco regulatory science, and behavioral economics. And also in that field, he's a co-author of the book, The Economics of Health Reconsidered, and a co-editor of the Behavioral Economics and Healthy Behaviors, Key Concept and Current Research, 2 big volumes. And also an expert on the US system, as he's a co-author of the Health Systems in Transition profile for the United States. So Andrew, please share us your viewpoints from the United States on social prescribing.
All right. Hello, everyone. Hello, yes, hello from across the pond, as they say. It is early here, but I'm very glad to be here. I've had some coffee and I'm ready to engage. So social prescribing in the US is still quite new. You know, one of our first case studies is a case study from Massachusetts, Culture RX, so prescribing culture, that really started in earnest after the pandemic. The planning for this had actually started in 2019, but implementation started pretty quickly after the pandemic, when there was a need for both socialization, but also importantly, ways to support arts in communities, which were sort of decimated right in the early phase of the pandemic. And so this was 12 organizations that had a relationship with clinical care providers, so organizations in the community like museums and dance studios and those kinds of places. It's currently undergoing an evaluation, and some later stages of that evaluation. So some of that evidence is coming out now. Other pilots have been implemented as well in the United States. So we're still, earlier on in our development here. And this is a field guide, which I can ask Alison to drop a link to in the chat. I sent her. This field guide is sort of for communities that are interested in developing social prescribing programs, particularly as they relate to like the arts. And so that's got several case studies in there and more information for those interested. It's very accessible, sort of designed for people in the community to read, to understand, to implement, policymakers at the municipal community level to implement. So that's quite helpful. But whereas much of the interest and sort of development of social prescribing in the US is sort of at this community level, this sort of pilot phase level, I'm going to talk next about a couple of places where at the systems level, the organizational level, there are ways to sort of sustainably finance social prescribing. And right now, where those opportunities lie is in our growing interest here, and I'm sure in other countries as well, in contexts in health-related social needs, which is, as Giada mentioned, sort of at the sort of broader level, health-related social needs that include things like employment and housing and transportation and so on and so forth. Socialization, right, which is sort of what social prescribing aims to do, sort of fits under that umbrella of health-related social needs. And under that umbrella, we do have a lot of activity happening nationally. So I'm going to talk about that next. I'm going to talk about two sort of examples that are sort of at scale. The first is accountable health communities. So many of you have probably heard of accountable care organizations that came out of the Affordable Care Act. Sort of an extension or a second generation of this model is something called accountable health communities. And this is a national pilot that sort of sits under the Center for Medicare and Medicaid Services, so the federal government. And it's 28 organizations that have a clinic and community partnership, right? So there's a clinic and a community partnership that's already been established. That partnership gets a per member per month or a capitated payment, and for patients and people in the community that are accessing this clinic and the community partner, as well as the community partner gets a lump sum annual payment to support, like, for example, link workers or other staff or services. And sort of what these partnerships do is they screen, right, for health-related social needs. They refer to the community. They help with the navigation to those services, and then they help sort of align. This is where we're talking about fragmentation in the poll. They help align sort of clinic activities and community activities around patient needs, right? And so there's a federal evaluation underway that the federal government is conducting, and so that is also in its later stages. So that evidence should be coming out soon. The second and last model I want to talk about is Medicaid. So I'm a Medicaid researcher, and so what Medicaid is it's a federal state partnership using public dollars, state dollars and federal dollars to cover low-income families in the United States. And so what's sort of interesting about Medicaid is each state has the ability and the flexibility to add additional benefits to its insurance package, and so that and it has to request permission from the federal government to do that, because the federal government pays about half of all of the benefits. So there's been a lot of interest from a number of states that are sort of shaded in here in various colors, and in using this public insurance program to pay for health-related social needs. And so that so far those include employment supports, housing supports, actually paying for housing, paying for nutrition supports, transportation, and so this is also where most of these public insurers are using managed care to sort of, as the mechanism by which to pay. And so these public insurers are also using the managed care organization contracts to ensure and that health-related social needs are being paid for, and to pay for things like link workers through managed care. And so this is where this is the financing mechanism through which something like social prescribing can be paid for, and where I expect it to grow, because we're seeing all this growth right now under this umbrella of health-related social needs, and this is the natural home for sort of social prescribing at scale in the United States, particularly as it relates to low-income families. So I'm going to stop there and pass it on so we can sort of start drilling into some case studies at the country level.
Thank you, Andrew. I can only imagine how complicated it is to organize this in the US system, which is very fragmented over private and public programs. Probably a topic we may get back to in the chat. Let's now go to Alison, who will introduce Daniela.
Yes, thank you so much. It's my pleasure to present Daniela Royat, Senior Health Expert at the Competence Center for Health Promotion and Health Systems at the Austrian National Public Health Institute. And as Ewald has mentioned, she's going to be speaking more about the social prescribing workforce and specifically training for link workers in Austria. Thank you for joining us, Daniela.
Thank you very much for the invitation and the opportunity to share a few insights in our experiences with social prescribing and link working. Firstly, I want to share some context on the situation of social prescribing in Austria. So we have experiences a few years with social prescribing, but only on a pilot level. So we had a program called Agenda Health Promotion by the Ministry of Health, which allows us to release funding calls to for primary care facilities. And we have now the third call running with 15 organizations participating. And in total, we have experiences with 24 primary care facilities piloting social prescribing. And according to our social prescribing scheme, link working is one central element beneath raising awareness of health-related non-medical needs, network management, and quality assurance. And as said previously, I will focus on this link working part. As part of the link working consultations, needs and resources are identified in dialogue with the patient to determine what is important for the person. And then an action plan is built and an attempt where appropriate is made to refer the person to suitable services in the region or counseling services. And also that the team is informed about the process of link working. The question I would like to shed light on now is that one of the qualification and training for health professionals with a link working function. And I like to say in advance that the answers are still under development and that I'm sharing the current status of implementation and considerations with you. Our approach is that a specialist with a link working function is not a new professional group, but that it's about the function of link working counseling that is in the center and should be in the focus. And this function should be carried out by a health or social professional who is ideally already employed in the primary care team and get some hours to do this link working function. And there we require in our funding calls people with 3 years basic training in a health or social profession like nurses, social workers, occupational therapists. And although it's mostly one profession fulfilling this function, there are also individual primary care facilities where the entire team is sensitized and tries to do the counseling when a need is shown up by a patient and takes the role of the link worker in cooperation with the whole team. So in preparation for the work and the function of a link worker, we conceptualized a short training course. And the training for the professionals with the link working function, are just 4 days. And when you hear this, you might think it's a short time, but I ask you to bear in mind that we are talking about an 18-month funding call and that a longer training don't seem possible in our context. And that the other thing that's important is that the implementation of this link working function builds on existing health and social professionals in the organization. So that are not somebody without any education and training in the health profession, but they are already quite good trained. So what does the training look like now? Contents are social determinants of health, salutogenesis, health promotion, to sharpen the resource orientation view and attitude of the health professionals. And of course, another important aspect of the training is the introduction of the social prescribing concept and the presentation and discussion of the key elements according to our ideal model of social prescribing, with the aim to familiarize the health professionals with these features and the concept and to find out about the similarities and differences to their previous activities. And elements in this are sensitization of employees, patients, and cooperation partners, the link working counseling, so the process design, how I can structure this in the organization, and of course also communication techniques like motivational interviewing. And we have also half-day training in communication with actors so that the health professionals can train their communication skills and refresh. Another aspect is network management, so to brainstorm potential cooperation partners where people can refer to, and also the quality requirements for these offers. So what you have to bear in mind when you ask somebody to cooperate on this basis. And of course, also an important aspect is the creation of an overview or database with the cooperation offers so that they don't have to find it out new every time. And of course, network maintains. And last aspect I want to point out is ethical and legal aspects. So addressing sensitive topics such as poverty in a non-embarrassing way, which is also important so that people can feel free and open in the counseling. And in addition to this, today, face-to-face training in a workshop format, there are further online sessions with case reviews during the funding period. And these case reviews from the implementers help to sharpen the understanding of social prescribing and to discuss challenging aspects. Yeah, coming to an end where we are standing now, we are currently trying to revise our trainings course and sharpen the profile for this link working function in order to proceed with our implementation of social prescribing in Austria. And with this, I hand over to Edward. Thank you very much.
Thank you very much, Daniela. I think this is a crucial, key factor whether social prescribing programs will succeed. How do you train link workers? I think we're really curious also to hear from you in the chat how you're doing it in your countries. But now we go to our next speaker, who is Cristiano Figueiredo. And Cristiano is a family doctor working in Lisbon. He's actually the co-founder and co-coordinator of the first social prescribing project in Portugal. He's also a lecturer at Nova National School of Public Health, and he's also the co-founder and coordinator of the Social Prescribing Portugal network. So he seems to really be the guy that we want to hear from today. So, Cristiano, thank you very much for joining us.
So, the idea today is to bring a very practical view on social prescribing and how it works in my primary healthcare unit in central Lisbon. I work in a family health unit, primary care unit, part of a local health unit called São José in central Lisbon. And we know that patients with different health-related social needs come to primary health care. It's very common, and is in a daily basis, these kind of patients make a booking with their family doctor, with their family nurse, and eventually they show up. So just to bring some example. I would like you to present the patient journey of two different patients that are typically approached by social prescribing in my local context. First, we have an elderly man. He comes up with his doctor with some memory issues. We notice he's suffering from some social isolation. And the second patient is a younger man. Is the kind of older man that is too young to go for retirement and too old to join workforce again. So he's unemployed and is getting overweight. He's suffering from obesity, and his doctor thinks he's suffering from some mild depression, low mood. So these patients, they use and they access primary health care. Eventually, they are overusers of primary health care. And when they go to their primary health care unit, and by that I mean their family doctor, family nurse, or even a psychologist based in primary health care, they may have some biomedical issues, but if there is enough time and a good relationship with the healthcare provider, these kind of social needs and emotional and practical needs will come up, okay? And so the role of the professional, let's say the family doctor here, is to identify the social needs that could be approached by a social prescribing program. If the patient accepts, the health professional will refer the patient to a a primary care-based social worker. So we are speaking about link workers before, so they play a central role in social prescribing programs because they bridge the primary health care, let's say, with the community resources further on. And so in our context, the social worker took the role of link worker, and they will have enough time to go in deep detail about what is the life conditions of these patients. So instead of maybe 1-2 minutes to speak about this issue, they will have about half an hour just to go through what really matters to that patient. And it may happen that the patient, if the patient agrees, there will be a co-production of a social prescription. And that social prescription could be like Tai Chi classes in some third age university, maybe some group visit to some local museum, or for the second patient to join some healthy cooking workshops in some local association, or to do some gardening in the local botanical garden, where he could be more active and get again some confidence, perhaps to go back to work. So this last part is what we call social prescription itself. It's a co-production of a plan between the link worker and the patient to address the broader social, emotional, and practical needs of a patient coming to primary health care. It takes a lot of work it's quite simple, the idea, okay? And it is almost common sense to implement something like this, but it takes a lot of work. We need first to get the team, the primary health care team, to prioritize the social determinants of health, to know how important they are and how they can address them in clinical practice. Then we need to get sure that we have a motivated link worker. It happens in Portugal, it was the social workers. So how can we engage with professionals already in the practice to take this role? Then it's very important for our health leaders to see how social prescribing as a priority. When you start implementing social prescribing, very soon after 2 years, we are facing a pandemic, and suddenly social prescribing was not a priority at all for the health leaders. And this is an ongoing process. There is always something more important to address, like lack of family doctors, waiting lists, and it's not easy to bring up social prescribing as a priority when you speak with health leaders. Then we need social partners. There is no social prescribing without associations, local partners, local authorities that provide different services and activities for patients referred to social prescribing. And of course, academia. Academia is very important for research, for guidance, and to bring up the knowledge necessary to influence health leaders to promote and invest in social prescribing. And last, and probably the most important, is essential to have the patients to understand what is social prescribing and how social prescribing activities and services can improve their health and well-being. And perhaps going to a doctor doesn't mean to get out of the consultation office with a pill. Maybe a social prescription or a referral for social prescribing could be better for their well-being. So social prescribing implementation, although looks quite simple, it becomes a very complex, multi-level and continuous process. We are doing this job for about 6 to 7 years, and it's an ongoing process, and you have always to go back and revisit each of these levels to make social prescribing work in practice. Thank you very much.
Thank you very much, Cristiano, and really also for showing the complexity of implementing this in practice level, and also making us aware that it also really hinges on the quality of the community resources available, whether this is going to succeed, and also the complexities and how to implement them. A good basis for further discussion. Alison, you've been monitoring the chat. I know that was very active, but please, so maybe you can feed some questions to our panelists.
Yes, absolutely. I've been furiously copying and trying to group the many, many good questions that we've received from our participants. And I think I would roughly say that the questions are revolving around really understanding better the role of health professionals, the relationship of social prescribing within the larger health system and with other interventions, governance questions, financing questions. There have been some great resources coming through. So perhaps we can start with some of the financing questions. I think there's one I've seen around financing and motivation that says, From Monica, she says, since the financing is often on the combination of the federal and local level, does this mean it depends on the goodwill of local policymakers? And there might there be a difference, kind of an evolving difference between the willing and non-willing communities? So that I think is more toward Andrew with the question around federal, local. But I do think this is common across different places, this question of funding. Asking whether or not there would be reimbursement schemes for participants or whether they might expect to have some out-of-pocket payments. And then relating this to policy, is there some way, a question from Rita, asking, since we see that there's some evidence showing a reduction in the burden on workers, could we consider a policy that involves companies to economically support this initiative, for example, for their workers? So maybe we start here around kind of financing more generally to understand motivations or policies, mechanisms, and then I'll keep working to group the questions together for another round.
Sure. Shall we then, as you suggested, perhaps start with Andrew, our first spotlight speaker?
Sure. Sure. Yeah, so the financing is because it is a federal state partnership, states are choosing, right? So they're selecting into these programs, these payment mechanisms for health-related social needs, which would extend to social prescribing. And so as you can see from that map that I showed, there's a dozen or so states out of the 50 here that have opted in to do that, and many of those states are more liberal on average, right? And so also have other sort of financing mechanisms for things like reentry after incarceration and broader substance use benefits. So yeah, but it is definitely sort of a coalition of the willing and not federalized at this point.
What does it look like in Austria? You were telling about this project you're doing, Daniela, but perhaps you can shed a bit more light on the financing side of how you do it in Austria.
Yeah, as I said, we are just in the piloting stage, so we have funding calls for a limited period of time to get a chance to get experiences with social prescribing, but there is not yet a solution how we finance it on a broader scale. There are some negotiations, but there is no solution yet, but we are trying our best.
And so where is the funding then coming from?
At the moment, from the Ministry of Health.
The Ministry of Health, okay. Cristiano?
So we have different funding approaches. So we didn't get any specific funding for the implementation. We got funding for the research, okay? And but soon, as we implemented the project, even though we had link workers already paid by the budget for healthcare, suddenly we had many more referrals, and the waiting list for social prescribing was increasing. So there was the need to employ more link workers or social workers to address the increasing of referrals to social prescribing, and that didn't happen. So that was a barrier to the quality of the service. And something that we managed to do was, even though the health sector could not apply to specific funding to create new services in the community, for example, as a team, we met different organizations in the community, and we supported them to apply to different fundings only available for the social sector. So we have about 5 different organizations we have supported to build up a new project, a new activity related to social prescribing, and to get specific funding for that activity. But as you say, they are short-term funding. So, for example, these healthy cooking workshops I mentioned before, we only had funding for 1 year. Okay, so after 1 year, the service was stopped because there was not ongoing investment. There is a hope for the municipalities to invest more on these kind of approaches, and there is also a project in Alentejo, in south part of Portugal, in a more rural area. They are getting some European fund for implementing social prescribing more related to culture. Okay, so there are different fundings going on, but I would say that from the health sector itself is still very poor. Okay, it's not a priority, and there is nothing specific.
Okay, so Giada, from the overview, is that also the picture you have, that the funding is an issue and that perhaps if you want to give this a fair chance to be implemented, countries would need to think of how to build an avenue into regular financing. Is that something we see in the overview?
We do have a mention, of course, funding is one of the pillars to also make sure that the programs have a fair chance of winning for the long term. I think there are also some issues with the division, let's say, between sectors. So sometimes it might be hard to identify a good source that's, especially in the long term, because things tend to evolve and change. But I wanted to briefly maybe touch upon one of the things that Alison mentioned, and how maybe some patients fear that they might not be able to afford it because they have to pay out of pocket. And I think from from what we saw, we didn't focus on it in our questions with the paper, but from the experience that we heard is that the resources are already available. So it's a rather low-cost way of connecting patients to what is already out there, and they might not be just aware of. And some things may be free, and some activities might have just a nominal fee. So in a way, it's done in a way that could be for everybody interested.
Thank you, Giada. Maybe going back to you, Alison, I know that you've been checking the chat box. I see more and more questions coming in. Maybe you can make a selection for us for a final round of answers.
Yes. I'm really struggling between, do I ask the questions on the roles of the health professionals or on the relationships between social prescribing and the larger health system? But some great questions around really, is it only doctors? Are there places where nurses can also make social prescriptions? How do we convince health workers of its importance if they don't have any financial benefit or incentive? Then if they don't have a very strong knowledge themselves around social determinants of health, how can they serve as good gatekeepers of the system? If they're not really aware perhaps of what a person would need, how do they know to make that link to the link worker? Some examples as well in Germany from having link workers integrated into emergency units. Some great information in the chat. And maybe we can get a bit more into the role of who's doing the social prescribing and how do we know that they have the skills to do it. It's hard to choose.
We can take this from so many different angles, and there's so much to discuss. But let's perhaps start again with Andrew. Andrew, what would be your reflection here? Is it a doctor? Is it a nurse? Is it somebody else? Who should it be?
Yeah, it's probably the the physician assistant, the nurse. That seems to be sort of the way, at least here, to the extent to which most of this is going to be done via primary care. That's probably the right provider, sort of to be the main prescriber, if you will.
Okay, Daniela.
I think our experiences show that that most frequently it is our doctors, but there are also cases where the whole team is sensitized for this needs, and every one of the team who finds a patient with this need or has the feeling there is something can do to say, okay, please have a link working consultation and try it. So it's not, I think it depends a little bit on the situation, and also how the social prescribing process is implemented in a facility. So if there's this team spirit that every contact counts, and wherever there is a need, we try to fulfill it, I think that could work very well. So we have examples of this, but of course, it could also be the physician-patient relationship with the trust in it, to help the patient to go to further counseling. So I think it depends a little bit on the situation and how the process is in the facility implemented.
Okay, so Cristiano, maybe you can give your opinion, but also maybe you can talk a little bit about this idea of having social prescribing in emergency care departments, where, as one of the commenters wrote, we see patients coming in again and again, and they would really benefit from these kinds of services. Do you see that in Portugal as well? Is it something you're thinking about? Is it already happening?
We have social workers based in emergency departments, but they are not engaged in a social prescribing perspective. So probably they will mostly address like homeless people, like very severe social issues, okay, not this health promotion perspective of intervention early on. Well, we about the referral for social prescribing, I think should be a all team approach. Okay, so it should be all team primary care approach. Let's say so. We try that every professional in a primary healthcare team is able to refer to social prescribing. So it means the family doctor, the family nurse, administrative staff, psychologists, and even the patient. Okay, even the patient can self-refer him to social prescribing with the support of administrative staff. And probably as important as who can refer is how is the patient referred. Should be a very simple process with clear referral motives and reasons, so that the professional doesn't waste too much time to do identification and referral, and that actually promotes the referrals to social prescribing, to make it simple and clear.
There, with that, you're also answering one of the questions I think we had. How do you convince and how do you get the workforce to get along and engage with social prescribing in the medical practice? So
yeah,
you already answered that question. Alison, shall we do one more question? A quick one? You select one, a good one from the audience. And then our panel will give very short answers, like 30 seconds.
Yeah, as a closing question, goodness, I think it would be interesting to understand how social prescribing ties to wider initiatives. There are quite a lot of questions around how does, as a patient-centered model, how does it relate to population health management? How does it relate to introducing digital technologies or nature-based solutions? There's a lot going on out there. So how does social prescribing really complement all of these other initiatives and take us further with what we're trying to achieve?
Okay, who would like to take that question? Cristiano, sure, go ahead.
I really think that social prescribing can escalate all of these initiatives that happen in our communities, because we kind of provide the users of these kind of solutions. So many times in the community there are different resources and different activities, and even though they have funding, sometimes they have problems recruiting the right people. Okay, and in the health facilities we have these long-term relationships with our patients. There is a lot of trust. And perhaps the health professionals can be good, screeners, a good person to identify who could actually benefit the most from these different programs in the community, including nature-based solutions or culture-based solutions. Everyone can win with the social prescribing approach, where health sector and social sector help each other to pursue their common goals.
Thank you, Cristiano. Maybe Giada, as a very final, because you were also the first speaker today. I know that we've been discussing that actually. What is the role vis-a-vis the other programs? So maybe your very short comment, and then we go to Caroline.
I think Cristiano said it very well. It's hard to compile everything in a very short comment, but I think if you want to have a good summary, I might direct you to the paper, because we also have a good table that looks at every different aspect, and you might be able to find all the details in there.
Perfect. Yeah, absolutely. Everybody should download the paper. But now we're going to Caroline Kostongs. Caroline, you will give some reflections of what you've heard today. You've been listening very carefully. So you have 3 minutes to give your reflections.
Yes, thanks a lot, Ewout, and so nice to see, to listen to all of the presentation and discussions, and in particular also the many comments in the chat. I am a fan of social prescribing, actually, because I see this is almost like a glimpse in the future, how our future health systems should look like, because at the moment our health systems are totally not sustainable. They are not able to deal with the persistent health inequalities. They are failing how to manage the increase of the NCDs, the mental health problems that are arising. Also, in terms of demographic change, it is not easy how health systems are going to deal with the aging. and all the chronic problems, the chronic health problems, but also social problems. Research also shows that in healthcare systems, there's an overconsumption in the sense that too many people are taking too many pills. We see a struggling workforce. And on top of that, we know that there is limited fiscal space, so will be less money available. So it is no doubt that our health systems will need to change quite drastically. So we need to change from the sickness system to the more health promoting systems. We need to move beyond the silo and work with other sectors, with the social sector, the employment sector, the housing sector. And we need to steer away from this centralized action, still quite dominated by hospitals, to more community-based actions. And I saw in the chat also the caring communities in Flanders. And here, I think, in the social prescribing, we can be a bit more ambitious. I know from Daniela in Austria that your pilots also include career advice or debt relief services. We could also think of making a link to social housing or housing. We really need to be ambitious there. And I feel social prescribing is really a great approach to pilot, to study, because we do need more research, but also to get data on effectiveness, how it works, effectiveness, how it reduces health inequalities as well. And with that information, we need to go to health leaders and step up our advocacy to health leaders, to politicians, to make the case for the change of health systems, for the investments in social prescribing approaches, investments in social activities, and so on. And we need to use the European Union instruments for this, like the European Semester, European Health Union. There are quite some discussions at the EU level on how making the health systems more sustainable. So we can insert into this debate. And also at the WHO, because in WHO you have the Astana process on primary health care. There is the talent charter on health systems. So I also think within WHO we have to steer and feed into the discussions there to make sure that we get this shift to more health promoting systems and embracing social prescribing in order to be fit for the future. And EuroHealthNet is keen to continue working with Observatory, Ewout, on this topic, as it is so important. Thank you, Ewout.
Yeah, wonderful. Thank you very, very much. I would like to thank all of you, our public, our audience, for joining us today. We really appreciate it. And of course, would like to thank all the speakers today for delivering their remarks. And I hope to see you all again. And I also would like to really thank Alison, my co-moderator. Let's do this again soon, okay? And have a nice day.